This is a presentation on anemia, understanding and interpreting low hemoglobin levels. Anemia is very commonly seen on routine blood tests and presents as low hemoglobin on a full blood count. Anemia is a state of either low red blood cell numbers and/or low red blood cell hemoglobin, or a defect in any other aspect of blood oxygen carriage. By definition, anemia is a hemoglobin of less than 2 standard deviations of the mean for age and gender. Different laboratories may use slightly different reference ranges, and subspecialist societies may have different cutoffs for certain patient groups. But in general, anemia is defined as a hemoglobin of less than 11 in children under 5 and during pregnancy, hemoglobin less than 11.5 in children aged 5 to 11, less than 12 in children over 12 and in non-pregnant women, and a hemoglobin of less than 13 in males. Because low hemoglobin results in poor blood oxygen carriage, transport, and tissue exchange, this can lead to a fairly non-specific range of signs and symptoms, including fatigue, poor exercise tolerance, weakness, the classical pallor of the mucous membranes, shortness of breath, headache, irregular heartbeat, sometimes heart failure, and can range from mild to severe. Anemia is not in itself a disease, but instead is a sign of one or more of various medical conditions. It should also be noted that anemias of different causes can also occur together, making the diagnosis of cause more complex. Some of the classical causes of anemia include nutrient deficiencies, most commonly iron, but sometimes other metals such as copper, and then folate and vitamin B12 deficiency, as well as protein deficiency associated with protein energy malnutrition. Anemia is common in chronic systemic diseases, especially if there is an inflammatory component, with exposure to toxic substances, including therapeutic drugs, alcohol, radiation exposure, diseases of the bone marrow, genetic disorders, immune and autoimmune responses, as well as infectious processes, frequently due to the inflammatory and hemolytic components, microvascular disease, acute or chronic blood loss, and other physiological states, including pregnancy, strong athletic training, and iatrogenic anemia. And this is an important cause of anemia in hospitalized patients who have repeated blood draws for routine biochemical monitoring and investigations. In order to understand and identify the type of anemia, one needs to look at both red blood cell size and hemoglobin content on examination of a full blood count. So a low hemoglobin on full blood count should be interpreted in the context of other parameters in the full blood count, the clinical and nutritional history of the patient, any medications being used, as well as signs and symptoms on a physical examination. To understand the type of anemia and the cause, it's essential to examine the cell morphology more closely. So in the context of low hemoglobin, in other words, an anemia diagnosis, let's start with the meaning of hematocrit. Hematocrit is roughly equivalent to packed cell volume, which is the percentage volume of the blood which is taken up by red blood cells. In an anemic patient who has a normal hematocrit, this suggests a proportional low number of red blood cells as well as the fluid portion of the blood. Patients with high hematocrit suggests that each red blood cell is large, or there are too many red blood cells, or there is a relatively low plasma volume. and by converse, a low hematocrit suggests that each cell is small, or there are too few red blood cells, or there is a relatively high plasma volume. On its own, hematocrit is not a sensitive marker of anemia type, and more information is required on cell size and features, the ability of the bone marrow to generate new red cells, and factors that might affect red blood cell lifespan, turnover, and destruction in order to interpret the cause of the anemia. Mean cell volume is one of the most useful indicators on a full blood count panel. Where the mean cell volume presents as normal, this suggests that the red blood cells are of normal volume and is referred to as normocytic anemia. If this state occurs, the appropriate second-line investigation is to investigate reticulocyte count. Reticulocytes are immature red blood cells and are an indicator of the capacity of bone marrow to produce new red blood cells. In normocytic anemia, which presents with a low reticulocyte count, this suggests a primary bone marrow disorder or poor hormonal drive on the bone marrow, such as in chronic renal failure associated with low erythropoietin levels. It can occur in liver disease and in anemia of chronic diseases, and this picture is also typical of the adaptive anemia associated with simple starvation or protein energy malnutrition without associated disease. If the reticulocyte count is high, this suggests that the bone marrow is responding to anemia by producing more red blood cells and frequently occurs after blood loss, in hemolytic states, or where there are other defects in the production of red blood cells. When mean cell volume is high, this suggests that the red blood cells are large and is termed macrocytic anemia. The appropriate second-line investigation here is to perform a peripheral blood smear. Macrocytic anemia presents in two classical ways. If megaloblasts are seen on the peripheral smear, this is referred to as megaloblastic anemia. Megaloblasts are often combined with hypersegmented neutrophils on the smear, and the presence of these cell types indicates a defect in red blood cell production due to a problem in the DNA synthesis process. This is the typical picture associated with multiple drug effects, including many classes of chemotherapeutic agents, antiretrovirals, and other therapeutic drug classes, but is also the classical presentation of folate deficiency and B12 deficiency anemia. Note that if B12 deficiency is identified, it must be distinguished whether B12 deficiency is as a result of diet, as for example in vegans, or whether it is pernicious and suggests a problem with intrinsic factor. Macrocytic anemia can also appear as non-megaloblastic when no megaloblasts are seen on the peripheral smear, and this is typical of heavy alcohol users, liver disease, copper deficiency, or a myelodysplastic state. Finally, if the mean cell volume is low, this suggests that the red blood cells are small and is referred to as microcytic anemia. The appropriate second-line investigation here is iron studies. If the iron is found to be low and associated with a low ferritin and high transferrin iron binding capacity, this is classical iron deficiency anemia. In the case of a low iron together with a normal or high ferritin and a variable transferrin iron binding capacity, this is associated with anemia of chronic diseases, inflammatory or infectious states, and malignancy. And the reason for this is that ferritin is in itself an inflammatory marker. and therefore will appear high in diseases with an inflammatory component. Iron studies can also return normal or high with variable ferritin and transferrin ion binding capacity levels. And this is more an indicator of an abnormal iron storage condition such as sideroblastic anemia or thalassemia. It is important to note that mixed anemias with both microcytic and macrocytic cells or nutritional anemias in the early stages may initially appear as normocytic, and therefore further investigations are required. In this case, we're referring to the red cell distribution width. Red cell distribution width is a measure of the variation of red cell sizes within a sample. Note, it is not the width of the red cell itself. In a sample of blood, red cell distribution width will return normal when all or most of the cells are of a similar size, so variation within the sample is low. This occurs if the red blood cells are all normal, and in this case mean cell volume will also be normal, or where the red blood cells are all abnormal but in the same way, for example, all are large or all are small, and the mean cell volume will therefore be applicably high or low. On the other hand, in a sample where there is high variation in the sizes of the red blood cells, the red cell distribution width will return high. Examples of this are where red blood cells are abnormal sizes for different reasons. For example, a mix of small and large cells or small and normal cells, and in these cases the mean cell volume may appear normal. This table shows an outline of typical patterns of mean cell volume and red cell distribution width, remembering that mean cell volume can be variable in anemia of mixed causes. Anemia of chronic diseases, patients with bone marrow disease, in blood loss, and following chemotherapy frequently presents with a normal mean cell volume and a normal red cell distribution width. Patients with a normal mean cell volume but a high red cell distribution width usually have mixed nutrient deficiencies or are in an early stage of iron or folate deficiency. Sideroblastic anemia can also present in this way, as can hemolytic anemias and anemias associated with liver disease. Iron deficiency classically presents as a low mean cell volume with a high red cell distribution width. Chronic diseases can present as a low mean cell volume with a normal red cell distribution width, and this distinguishes the anemia of chronic diseases from classical iron deficiency. And then finally, a high mean cell volume with a high red cell distribution width is typical of folate or vitamin B12 deficiency anemias. Please press pause on your video now if you want to study this table in more detail. Finally, let's look at mean cell hemoglobin. Mean cell hemoglobin is the hemoglobin content of the average red blood cell in a sample. Mean cell hemoglobin concentration, on the other hand, is the amount of hemoglobin in a given sample of packed red blood cells. It is important to realize that the mean cell hemoglobin is proportional to the mean cell volume. Cell size in red blood cells is largely determined by the hemoglobin content of that cell. Because there are no other organelles in a red blood cell, the cell content is therefore almost exclusively hemoglobin. Cells which present with a normal hemoglobin are referred to as normochromic. Those who present with a low hemoglobin are pale under the microscope and are therefore referred to as hypochromic, and cells which have a high hemoglobin content appear dark and are therefore referred to as hyperchromic. Again, this table indicates the typical patterns of anemia with reference to mean cell volume and mean cell hemoglobin. And as we've said before, normocytic normochromic anemia is typical of chronic renal failure, blood loss, chemotherapy, and in some bone marrow diseases. Normocytic hypochromic anemia is the classical presentation of the adaptive anemia associated with simple starvation. Iron deficiency is classically microcytic hypochromic, and some forms of vitamin B responsive anemia also will present in this way. Macrocytic hyperchromic anemia is the classical presentation of vitamin B12 deficiency and folate deficiency. Note that macrocytic normochromic or macrocytic hypochromic anemia is a regenerative phase of anemia and is a temporary state as the patient recovers from the anemic state. And it occurs because reticulocytes are relatively large compared to mature red blood cells. So the state appears macrocytic, but reticulocytes also appear slightly paler because they have not fully completed the hemoglobin synthesis process. So this is a transient state that you will sometimes see in a patient who is recovering from anemia rather than an anemic pattern itself. Note that the anemia of chronic diseases can present in various different ways. This summary slide indicates the typical features and causes of anemia. On the x-axis is increasing red cell size, and on the y-axis increasing red cell hemoglobin, with the grey bars indicating normochromia and normocytosis here. So iron deficiency, as we've said, classically presents as microcytic hypochromic, the anemia of protein energy malnutrition as normocytic but hypochromic. Normocytic normochromic anemia is associated with blood loss, chronic renal failure, mixed nutrient deficiencies, especially in early stages, chemotherapy, and in bone marrow disorders. Note that the anemia of chronic diseases can present in a variety of ways in this range. Macrocytic anemia is common in alcohol users and with liver disease, and megaloblastic forms of macrocytic anemia are associated with folate and vitamin B12, as well as the effects of drugs on bone marrow. And then note that the regenerative stage of anemia frequently appears as very macrocytic but relatively hypochromic because of the large size of reticulocytes but the lower levels of hemoglobin in these cells. Please visit the website criticalpoint.co.za to find the anemia management protocol you see on the screen for download, as well as other similar useful downloadable algorithm tools for use in your practice, or contact us for a special request.